Ladies and gentlemen, I'm very honored to be here to introduce our technology regarding to biofabricate the patient-specific tumor-on-a-chip system for medical prediction. Here comes my CV. My name is Evan Chen from the China Medical University. My expertise is active manufacturing, bioprinting, organ-on-a-chip. Here is our team. We have very deep cooperation with the National Tsinghua University, National Taiwan University of Science and Technology. Of course, our China Medical University's physicians and researchers. We are very lucky to have several honors, awards, patents, and we also tech transfer to the previous tech to the industry, which means our team is really focused on the academic to the industry cooperation. Today, I would like to talk about the cancer treatment, the unmet needs in lung cancer. In lung cancer, we have precision medicine for target therapy, which is EGFR TKI drugs. When the patient has been detected EGFR mutation, the physician will give him or her the EGFR TKI drugs. However, those drugs only have 60 to 70% for the response, which means there are 30% to 40% patients non-response to the EGFR TKI, even though they have EGFR mutation. So we are thinking about what if there have a precision in vitro cancer model to predict the drug efficacy. So what kind of in vitro cancer model we can choose? We need to consider the cost-friendly, the high throughput, the traceable systems. So our answer would be tumor-on-a-chip. Before we talk about our technology, I'd like to talk about tumor microenvironment. Tumor is very, very complicated, including not only cancer cell, including a lot of cell systems like blood vessel, immune cells, fibroblasts, ECM, and so on and so forth. And those tumors need to have the hypatia gradient. So consider all those parameters. We already set out our requirement to the tumor-on-a-chip. The tumor-on-a-chip need to very mimic the microenvironment. So we need to combine those different cell systems together. And tumor-on-a-chip need to be easy to fabricate, need to be easy to perform the quantitative assay, and it need to be rapid and high throughput outcomes. So with all those requirements, we start to find out how can we achieve those goals. The first technology I would like to introduce is we are able to fabricate the multi-size cell microvessels. So we're using our bioprinter to control the cell cluster size, which means we can control the cell number, and then in the end, we can provide the quantitative assay for the patient and for the physicians. The second technology we have developing is cell cluster. The first one is the organoid. Organoid contain higher than 90 to 95% cancer cell. But as we have mentioned, in the tumor microenvironment, it's not only about the cancer cell. We need to consider other cell systems. So we have a second technology we call the cell block. We contain the patient's primary cell together with patient's cancer cell, with patient's fibroblasts and the immune cells. So when we combine the two systems together, we put the organoid in the middle, and we surrounding the patient's primary cell, calf, HUVEC, and the immune cell together. And that then to self-organize and to self-matured. And we find out the tube vessel has been formed and then penetrate to our organoid, which is very similar to the real patient's tumor microenvironment. Not only this, we also developing our own automation equipment, which is bioprinting. We can automatically load the ECM, the cells cluster, and the other cell system together. That then mature, that then self-organize together. And after a few days, when the system is ready, we are able to test the drug to see the drug efficacy. So in the drug analyze, we treat those models with the cancer drugs. Usually it's the commercial drugs. And then after that, we stem for the assay. And then we use a microscopy to observe the cancer life and death image. And then in the end, we get the cancer viability to our patient, to our physician. So it's a quantitative assay to cancer treatment. And all these procedures need to be done in 14 days. So we also using our in vitro model to collaborate with our physician. We have done the clinical trial for 24 lung cancer patients. Then our in vitro system has reached the 87% accuracy, 88 sensitivity, and 85 specificity. And we also analyze the gene distribution from the patient sample and the cell cluster in our chips. And we find out they have a high similarity of the gene distribution, and they have very similar cell group distribution to each other. So we believe our in vitro model is really biomimics to patients' real tumor microenvironment. In all the 24 lung cancer patients, there are one patient is most significant. This patient has been detected lung cancer in January, and the physician decided to give him the traditional treat strategy, which is carboplatin and anita combination. And after a few months, we find out, if you see the X-ray over here, we find the disease isn't controlled. The lung cancer has become serious, and the disease has been progressed. So on that time, our CHIPS result has come out, and the physician decided to change the strategy to the cisplatin and the gemcitabine. And after a few months, the patient come back. Then we found out the disease has response to the drugs. We can see the CT image over here, the white area in the red circle. That's the original tumor area. And after the right drug treated to the patients, the tumor area has been shrunk down, and the disease has been under control. So we believe if we are able to give the patient and physician the right strategy before they're doing the treatment, they'll be help the patient to prolong their life, help the physician to control the disease. So that's our end goal for this project. So thank you very much.